So before, let us discuss the situations or the points which has been discussed previous to the ischemia trial, where we were before the ischemia trial. We had the courage trial in 2007, and what was the trial? 2,287 stable ischemic heart disease patients were randomized to PCI with remember that first generation DES plus OMT versus OMT. And their follow-up was 2.5 to 7 years, high baseline coexistence of multiple comorbidities and documented ischemia. No reduction in primary endpoint of death or non-fatal MI or MACE. Revascularization with CABG definitely showed benefit. Now then came the Barry 2D trial, which was published in 2009. 2,368 diabetic patients randomized to CABG versus PCI. Further, each stratum randomized to OMT versus OMT plus revascularization procedure. No difference in primary endpoints of death and MI. However, there was a benefit seen with CABG in high-risk subsets, unlike PCI. And then came FAME2 trial, where he used what Dr. Datta was discussing, the intravascular coronary physiology, that is FFR. And by using FFR and heart team approach, this FAME2 trial 2012, that showed 1,220 patients of stable ischemic heart disease with FFR less than 0.80 were randomized to optimal medical therapy plus revascularization versus optimal medical therapy alone. And there is a reduced primary endpoint of death, MI or urgent revascularization when PCI was done in hemodynamically significant stenosis. And you can see the curve, there is a definite splaying of the curve, and there is a definite improvement when there is after using this FFR to show that there is a significant obstruction. I mean significant physiological obstruction. Now then the ischemia trial came. We know that this ischemia trial, it was a randomized controlled trial, multi-center trial, about 16% of the patients from the US, and about 5,000 plus patients were taken for this trial. And there, all these patients at first we have to demonstrate that they are having significant ischemia. So ischemia testing inclusive criteria in these patients in this ischemia trial. One of these 4 non-invasive ischemia producing tests were done: nuclear SPECT, CMR, dobutamine echo, or ETT. Either one of them, one of these 4. And you can see that what are the criteria: more than 10% of the myocardium ischemic in nuclear SPECT, in CMR, more than 12% perfusion defect, in dobutamine echo, more than 3 by 16 segments showed abnormality, and ETT. These are all 4 must be met to show that they are having significant moderate or severe ischemia. And you can see that it accounted to 75.5% of the total patients in ischemia by these 3 tests, and ETT showed 24.5% of the total patients in ischemia, and 83% of them were severe according to the criteria. So that was, must. So now, what are the details of this ischemia trial? I told you more than 5,000 patients with documented Canadian Cardiovascular Society class 1 and class 2 angina. Remember that this is a class 1 and class 2 angina. That means low risk patients were taken. And ischemia or non-invasive testing, what we demonstrated just now, and they are stable patients, that means stable ischemic heart disease, and mean left ventricular ejection fraction in these patients were 60%. Minimum ejection fraction was about 38%. Now, blinded CT angio was done before starting this protocol, because to rule out this left main disease or normal coronary arteries. And then optimal medical therapy on one side, optimal medical therapy, cath reserved for refractory angina. Of course, any patient who is on optimal medical therapy, and if they are having angina in spite of optimal medical therapy, you have to go for cath and revascularization. And then invasive therapy, OMT plus cath plus PCI with a second generation DES, oblique CABG as deemed appropriate by a heart team approach. So we had a heart team approach, and after taking the decision from the heart team approach, we went for whether DES, PCI or CABG. Primary endpoint, CV death, cardiovascular death, or cerebrovascular death, heart failure, or sudden resuscitated death, cardiac arrest. Then ischemia protocol. In this ischemia trial, you can see that this protocol, and I think all of us, we are aware of this, this protocol. and whether invasive strategy and conservative strategy. In invasive strategy, this anatomy is suitable for revascularization. After opinion taking from the heart team, we are going for PCI or CABG. And if there is obstructive CAD not suitable for revascularization, medical therapy. If there is a significant stenosis as assessed by FFR, then if it is more than 0.8, go for PCI or CABG. If not, then no revascularization, continue optimal medical therapy. Then ischemia results, you see the results, this primary outcome at the beginning, at the 6 months to 1 year follow-up, you see there is a mild difference between the conservative therapy and invasive therapy. And then after 2 years, you see a little bit there is a change in the curve, and there is some amount of difference between the conservative therapy and invasive therapy, but you can see that conservative therapy was better than invasive therapy. In fact, that also p-value is not significant, so there is no significant change in the hazard ratio between the conservative therapy and invasive therapy. So this is the ischemia result trial which has been published. Now, so all-cause death also from this ischemia trial, you can see that there is no gap in the curve between the invasive and the conservative therapy. So there is no change, no significant all-cause death between the two modes of therapy. That means between the conservative therapy and the invasive therapy. So what we are going to do, to stent or not to stent in this group of stable ischemic heart disease patients? The question is, the question should be faced by this interventional cardiologist, whether you go for angioplasty or not in these patients. Let us come to that. Now, in general, what we are doing? CAG and revascularization is indicated when? Severe symptoms despite optimal medical therapy, multivessel disease with LV systolic dysfunction. It is generally accepted that severe ischemia on imaging or other adverse risk factors on stress testing are indications for angiography with a view to improve prognosis. However, the presence of moderate to severe ischemia alone, as per the ischemia trial, may not be an indication for early coronary angiography and could be initially treated with optimal medical therapy alone. So, in fact, this we know from the very beginning that optimal medical therapy is quite sufficient in this group of stable ischemic heart disease patients. And this, of course, in patients who have already undergone coronary artery angiography in the background of stable ischemic heart disease, and you know that as recommended by ESC, leave aside the left-sided curve because this is complete trial which is in relation to the after acute myocardial infarction. Now on the right-hand side, you can see the protocol. So these are the ischemia, different types of ischemia, and in the lower down you can see the anatomic severity. So you have to consider the ischemia severity and the anatomic severity. Only if we consider the ischemia severity, and you can see that there is no significant risk difference after revascularization. But if we consider the anatomic protocol, you can see that, so ischemia protocol, there is no significant difference. And then if we consider the anatomic protocol, that is severe disease burden in coronary artery disease, definitely there is a, yes, it differs. So, also if we consider the COURAGE trial which was previously published, we have to consider the degree of severity of coronary artery disease anatomy, and then only you can predict what is called death, MI or NST, that is a significant difference, but not with only ischemia. So conclusion, in a cohort of patients treated with OMT, anatomic burden was a consistent predictor for death, MI or non-ST elevation ACS, whereas ischemic burden was not. So, whether this ischemia is a utopia or dystopia. Previously we thought that ischemia is a utopia, but after this ischemia trial, I think it is just a dystopia. So this is another START trial from Italy. Also it said same results like ischemia trial. Now, so how to summarize this? After this ischemia trial in stable ischemic heart disease, what we are going to do? Decision to revascularize in SIAHD is based on symptoms, anatomic burden, hemodynamic severity, and LV systolic dysfunction. In general, a combination of these factors, never alone. Based on ischemia results, ischemia alone is a proof predictor of long-term outcomes in SIAHD patients. When revascularizing in borderline disease, use of FFR is a must to justify PCI or CABG. Guideline-directed medical therapy in optimal doses is mandatory along with good comorbid control and lifestyle therapy. Thanks for patient hearing.